Okay, we are going to talk about Competency 7, Cardiovascular Physiology, OpenStax chapters 19 and 20, Patent chapters 28 and 30. Now, this is a heavy weight, to say the least. There's a lot of information. In a normal 15-week course, we would go through this over 2 weeks' time. So I put so you notice the PhysioX assignments are a little beefier. You're going to have two this week to do two exercises 5 and 6 from your PhysioX, all activities. Now I've put videos up for all of the activities in for exercise 5. Some of the information I'm going through today is better explained or more explained in the PhysioX. So make sure that as you're doing those, you're connecting what's going on with this particular discussion. So anyhow, I will be putting the exercise 6 videos up sometime soon. So on the bright side, there is no Competency 12 PhysioX. So you have 12 total over the course of the semester. This particular competency does have 2 with all activities. So keep that in mind. If you have questions, please let me know. So as I stated, that pretty loaded information. We're going to go through some of the basics of EKG, heart, nerve conduction, the flow of blood through the coronary system. We'll also look a little bit at pressure and different mechanisms with hemodynamics, which again, PhysioX 5, exercise 5, goes through quite a bit of hemodynamics and what you would find in chapter 30 in Patent's text or chapter 20 in the OpenStax. PhysioX 6 goes through cardiac cycles and applies more to what's in chapter 28 of Patent or 19 in OpenStax. So anyhow, let's get to it. I just want to spend a couple minutes going through some review of the heart and where it's located. Again, we see the heart contained in a pericardium, which is going to be connected with the diaphragm. We call this the visceral pericardium, covered up superficially with the parietal pericardium. So we can see the parietal pericardium here. We've cut away looks like the parietal pericardium here. So we could see part of that visceral or pericardium deep to that. So anyway, just a couple of side notes. A review. Let's see. Let's get into, here we go. This is the one I was looking for. Heart and great vessels. So in general EMP, we briefly discussed these coronary arteries. Those of you who had me for general, maybe remember filling out a worksheet that identified some of these different cardiac or coronary arteries and cardiac veins. So I'll go through those in a little more detail today. But of course, the aorta, the great vessels, the superior vena cava doesn't show, but the inferior vena cava, both coming into the right atrium. And then, so the right side pump, right atrium from the body, blood coming from the body via those vena cavae. Okay, then we pass through the tricuspid valve and head down into the right ventricle and then out into the pulmonary trunk and these pulmonary arteries heading to the lungs. So we'll be looking at a little bit more detail regarding how that's regulated the flow of blood through the heart is regulated electrically, and how these atria and ventricles contract. And again, you recall the right side is receiving blood from the body with low oxygen, sending the blood away from the heart out to the lungs. And this is, again, this pulmonary artery group is the only group of arteries that is going to be low in oxygen, or carrying blood low in oxygen. Okay. And then as we bring blood back to the left side of the heart from the lungs via the pulmonary veins, we're going to enter into that left atrium, pass through the mitral or bicuspid valve down into the left ventricle, and then out through the aortic valve and out into the aorta. So we see a posterior view, and we can see that inferior vena cava or vena cava and the superior vena cava, both vena cavae running right into that right atrium. And then again, we can see the left pulmonary veins coming in and dumping into the left atrium. And again, the heart is very thick. We've got multiple layers. We have the myocardium, the thick innermost, or innermost, but the thick muscle layer, with that innermost or deep layer, the endocardium, making up the area of the chambers where the blood is going to be making contact with the heart. That myocardium is where we're going to find a lot of the, pardon me, a lot of the nervous tissue embedded. And then, of course, we have the epicardium and the connecting with the pericardium. And we can see that pericardial space here as well. So we have the visceral layer of the pericardium, also called the epicardium, pericardial space, and then that parietal pericardium. Okay, and as we look inside, we again notice that right atrium and left atrium, or the two atria being smaller chambers, a little more, they appear that way. They are more flexible. They can expand a lot better than the ventricles. Their muscle tissue is similar to what we'd maybe see with bladder tissue. It's still, or smooth muscle tissue. It still has the ability to extend and empty blood into the right ventricle or the left ventricle. Okay. So anyway, right atrium, right ventricle, the tricuspid valves in between, left atrium, left ventricle with the mitral or bicuspid. Okay. Then we again see the aortic semilunar valves. Well, we talk in the PhysioX about afterload, after the ventricles contract and eject blood into the aorta. There's going to be a back pressure going against these semilunar valves. And in order for these ventricles to be able to eject blood again past the aortic valve, we have to overcome the afterload pressure that's being placed against the valves. Okay. And then we talk a little bit about preload as well in the PhysioX. So you'll want to, again, watch those videos. The preload is the end diastolic volume, or the ventricles being full. So anyway, I don't want to belabor this. This should be a review for you, so you can certainly go back and look through the structures of the heart and the flow of blood through the heart. Okay, so we're going to take a peek at some of these coronary arteries and coronary cardiac veins. So the coronary arteries are going to be feeding the heart muscle itself. So the ventricles, of course, are going to be involved with this. So as we look at the ventricles, we can see that there's a connection with the aortic semilunar valve. So as oxygenated blood is coming into the left atrium, we do see and then subsequently filling up the left ventricle, we do see blood passing into the coronary arteries. And then certainly as we eject blood, from the left ventricles, we're going to be feeding uh, the heart via those two pathways. So we do see a left coronary artery branch. It's going to feed the left side of the heart, and a right coronary artery branch that's going to feed the right side of the heart. And then we have a couple of branches coming off of each of those that we'll take a peek at. We have coming off the left coronary artery, we have what we call the circumflex artery. And then the other branch is going to be the anterior interventricular artery, also known as the left descending artery. Okay, or left anterior descending artery even. So anyhow, LAD is the clinical reference term for this. So anatomy, we call it the anterior interventricular. In the clinic, it's called the left anterior descending artery. Okay, and then coming off, we've got the right coronary artery and a couple of branches off of that. We can see the posterior interventricular artery wrapping around. This is implying that it's going behind the heart. That's why it's not as brightly colored. But that posterior interventricular artery, also known as the posterior descending artery. So let's see, and then we have the right marginal artery, and then subsequent branches off of that. So when we look at the flow chart off of that ascending aorta, we're going to see these first two branches of the left coronary artery and the right coronary artery. That right coronary artery again is going to kind of go back behind and feed the right side of the heart, as well as the posterior aspect of the heart. Again, also known as the posterior descending artery in the clinic. The marginal artery, you can see, stays along the right margin of the heart, hence the name. Okay. And then again, those are both going to branch into even smaller arteries. Look at the left coronary artery and see that it also has two branches, the circumflex branch heading along the left margin, and then a little bit posterior, wrapping around the left ventricle. And then the anterior interventricular branch here, also known as the left anterior descending or LAD branch. And then that branches further into the septal artery, and then, of course, the circumflex branch into some of these other ventricular branches. When it comes to returning the venous supply, generally we would see, just like we see throughout the body, veins following parallel with arteries, just bringing low oxygen blood back to the heart. Well, certainly the cardiac veins aren't going to have to flow very far. We're going to see a coronary sinus here, where we're going to be dumping from the great cardiac vein, small cardiac vein, all dumping their middle cardiac vein, all dumping blood into that coronary sinus. Okay. And that coronary sinus is going to dump into directly into the right atrium. It's going to pass along with the inferior vena cava. If we go back, where was that? You can see the great cardiac vein. That everything dumping into this coronary sinus that's going to dump right into the right atrium. You can see it snug right there with the inferior vena cava. Okay, so coronary veins or cardiac veins. All right, let's move into nerve supply of the heart. We looked at this in general as well, so some of this terminology shouldn't be that unfamiliar to you. Again, we have modified cardiac muscles containing these specialized nodes, and these nodes are going to be producing and distributing these electrical impulses. So we also see cardiac plexus near the arch of the aorta. We see what are called baroreceptors or pressure receptors at the arch of the aorta as well. That helps the those are afferent pathways. So they're basically sensors. So we can deliver information to the brain, telling the brain really how much, how often, how forceful blood is ejecting from the left ventricle. So we also see little bundles of nerve buttons there, and again, acting as afferent pathways or sensory pathways going to the central nervous system and brain. Basically communication pathways. So not only do we have the efferent pathways coming into the heart and connecting with these nodes, even though the SA node particularly is specialized enough to create its own action potentials without the constant vagus stimulation. That's still connected. The vagus nerve coming off of the brain. Let's see. So anyway, those are efferent pathways, motor pathways, and the heart again has the afferent or sensory pathways that will communicate with the brain regarding some of the contractile properties. Okay, so the main structures, of course, that we saw in general A&P, we saw the SA or sinoatrial node at the roof of the right atrium, and then branch coming down into the AV node at the kind of the basement or the floor of the right atrium, and then branches of the AV node travel down through the interventricular septum, these bundle, what we call the bundle of His or the AV bundle, and then those bundles have branches called Purkinje fibers or subendocardial branches. Okay, so systemic or rhythmic impulses coming from that SA node. So that SA node will initiate heartbeat and set the pace. Again, an intrinsic rhythm contained within those specialized cells. Each impulse from the SA node is going to travel over to the left atrium and stay as well within the right atrium. So we'll see some branches traveling over to the left atrium. Okay. So as the action potential travels from the SA node down to the AV node, we're going to see a slowing of the conduction of electricity to allow those atrial chambers to fill to maximum before we initiate the contraction of those atria. Okay, and then after the AV node, we're going to see nerve conduction velocity increase and travel into those AV bundles or the bundle of His. And then we're going to have a right and left bundle fiber branches, and they're going to branch into those Purkinje fibers that will travel and wrap around the myocardial aspect of the ventricles. So we start at the atria, And the SA node, we can see the pacemaker, and then we have this atrial bundle of nerve fiber that travels over to the left atrium. And then we see what are called the internodal bundles, bundles that come off of the SA node and go between the two nodes, the SA and the AV nodes. So there we can see these internodal bundles. Okay, so the pace gets set by this SA node. Action potentials, nerve impulses are generated and travel to the AV node and over to the left atrium. Okay. And then as the ventricles, so when we need these, the two atria also contract. We oftentimes talk about ventricular contraction and ejecting blood from the heart, but there's more to getting blood from the two atria down into the two ventricles than just pulling open a trap door. We do need to get some contraction to occur, some emptying of these atria. So there is some atrial contraction that is going to be encouraged by the generation of impulses traveling along these interatrial bundles and internodal bundles. And then once we get to the AV node and start traveling down into the ventricular walls, we can see these Purkinje fibers that are going to initiate or can perpetuate the action potential that was initiated up here. And ultimately, we're going to be able to encourage and enable this cardiac muscle wall of the ventricles to contract and eject blood out of the heart. So, little flow chart, sinoatrial node. We send the stay in the right atrium. If we go over to the left atrium, we call those interatrial bundles of fibers, and then the internodal bundles, of course, traveling between nodes. And then as we leave the AV node, we come again down into these bundle branches and ultimately out into the Purkinje fibers. And we can see these terminate in the myocardial aspects of the two ventricles. So the cardiac action potential, very similar to what we see in normal cells throughout the body, or I shouldn't say normal other cells, cells other than cardiac cells. Again, that SA node, that intrinsic specialized group of cells that are able to generate the action potential. And then throughout the heart, we have these myocytes or ventricular cells that also are receiving the message and perpetuate and continue the action potential. At negative 90 millivolts, we're at rest. Now, we saw with other cells, nerve cells throughout the body, that number is negative 70 typically. So we do see polarized occurring at negative 90 millivolts. And then again, same principle applies when a stimulus comes in. We're going to see sodium rushing into the cell, depolarization occurring. We're going to see a high number of positivity in regards to ionic movement into the cell. So sodium, and again, potassium's just kind of hanging out inside the cell as sodium's rushing in. There is a little potassium leaking out, but it's not like we have this sodium goes in, potassium goes out. Initially, potassium's going to stay in there. Which is, remember, potassium's also positive. So as sodium rushes in, we then get this really large increase up into the positive range. So from anyway, our threshold potential is negative 40 millivolts. So depending on the strength, and again, this is heart muscle. So there's usually not much of a, depending on the strength of stimulus, we're not relying on the nervous system from the brain to be telling the heart what to do. So this is going on 60 to 100 times per minute, where we're getting polarization, and then the influx of sodium ions into the cell to the point where we get to a negative 40 millivolts. That's going to trigger an action potential to occur. We're going to get to that 50 millivolts positive as our peak of depolarization. At that point, potassium ions now rush out of the cell, and we start the process of what we call repolarization. So that repolarization is kicking potassium out of the cell, and what we end up with is seeing everything during repolarization, you'll recall, starts going back down to the baseline, to that negative 90, which is the baseline for being polarized. But again, we have hyperpolarization typically because these potassium leak channels with potassium rushing out, they're voltage gated channels causing potassium to rush out. They're a little slow to close. So that's why we do get a hyperpolarization or a hyper polarization, meaning we go below that negative 90. So we may be at a negative 100. So, but anyway, that does trigger sodium potassium pumps to start working and attaining equilibrium and getting us back to being completely polarized again. So we can measure the electrical activity via this an EKG or an ECG. Electrodes are attached to the patient. There are multiple different what they call lead sites. So sites where we can place the stickers and place the wraps if we if we have them for the appendages. So there are different there are different lead settings. So that could determine what we see on an EKG. So anyway, this is what a typical EKG or ECG is going to look like. We see what's called a P wave, then this QRS complex, and then the T wave. Now, it has voltage over here, labeled 0 up to 0.5 millivolts. So we're going to use those as our standard, even though we were just looking at this. We're just going to use this as our baseline for voltage just to simplify what's going on. So anyway, what we have at rest or being polarized, we're at the 0 mark. Once we get an influx of sodium going in, an action potential gets generated, we're going to see what's called atrial depolarization. So the P wave represents the beginning of the atrium or the atrial cells depolarizing. And again, what that means is sodium is rushing in, and we're getting ready for something to happen. Okay, and action, there's potential for action to occur. And so again, this is measuring the electrical activity. What immediately follows this P wave, so right at this spot, would be the contraction of the atrium. So the atria are going to squeeze and contract blood down into the ventricles. So that's what's going on here. Okay, so sodium's rushing in. We're getting everything prepared. We get that peak, and then we see some uh, repolarization occurring. And then if we look at the next wave, so at this point here, we're seeing the ventricles are filling. So, and the ventricles are going to continue to fill all the way over to the end of this QRS complex. Okay, so the atria have filled, the atria are filling, and then we're prepping the atrial muscles to contract and send the blood down into the ventricles. And again, we don't need a strong force of contraction to send blood from the atria down into the ventricles. That's part of the reason why we don't see a large P wave typically, is because we don't need a strong force of contraction. So anyhow, as we see, we start repolarizing, and then we get some hyper polarization going on here. So the QRS complex is gonna be the atrium repolarizing, meaning again that we're going to see potassium rushing out of the cell and causing things to get polarized again. And when potassium rushes out of the cell, remember, sodium is staying in the cell. That's not where we want to be. We're going to see polarization in that, but we have our ions on the opposite side of the membrane. So there's a little bit of a time lapse or a gap where we need to get the sodium potassium pumps, getting 3 sodiums pumped out of the cell and getting 2 potassiums pumped back in. Then we get the ultimate in regular polarization. So when we say we're repolarizing, it sounds like we're going back to being polar, which we are, but we're not. We don't have the ions on the correct side. We have the ions. Again, sodium is in, potassium is out after an action potential. So we need to get equilibrium back again and get sodium back out of the cell and potassium back in. So anyway, that repolarization of the atria is enabling or preparing the atria to receive more blood and then to be able to start this process again. Well, at the same time that the atria are repolarizing, we're also we just got some physical action with after that P wave of the atria contracting, sending blood down into the ventricles. Now the ventricles need to prepare to get a contraction developed and established. So an electrical impulse has to trigger those ventricular cells to contract. So that's what the QRS wave also represents, is an extreme amount of sodium rushing in and extreme depolarization occurring down in those ventricular cells. And then we see that repolarization happening again, continuing with the atria. Okay, so we're at the QRS is the electrical impulse that's generated and shows up on an EKG that is implying too by the amplitude or the size of that wave that we're going to see the result as a more forceful contraction, a more forceful event. So give it give the atria a little bit of a jolt, bzz, and then they're going to contract and inject blood down into the ventricles. Then we give the ventricles a strong jolt, bzz, okay, and then we get the ventricles to contract with force to eject blood out to the lungs and certainly out to the body. So again, we see that QRS wave much larger, thus showing a more forceful contraction. Okay. So anyways, that contraction is occurring here. And then after the contraction, the ventricles are getting stabilized again. They're going to prepare for another P wave, but in order to get that to happen, we do need to get we see sodium rushing out and potassium, I mean, rushing out. We see that ventricular repolarization. Usually, we think of repolarization, being more of like an inverted wave, but because of there's a double negativity effect going on with the cells regarding movement and electrical impulse. So we do see a double negative creating a T wave that is in the positive direction. So, and because again, we have so much activity and so much sodium influx for that depolarization, and we see potassium efflux or potassium leaving. We're going to see that potassium rushing out as a pretty big hump relative to what we normally see with repolarization. Okay, so there was something else I was going to mention here as well. Oh, and the T wave typically isn't symmetrical, it's asymmetrical. You can see how it's repolarizing. It's a little more of a long incline. We get to a peak, and then there's a little bit of a sharper decline. You can kind of see that there. So, but that's a normal look. T waves can be fairly large. We can have kind of a humpback T wave. T waves, so the ventricles uh, showing a lot of repolarization that could be ischemia or fluid building around in the pericardial space. And so we've got some, the heart has difficulty basically going back to its reset point. So because the fluid in the pericardium is pushing against the ventricles, so the ventricles have a more difficult time, in essence, relaxing and repolarizing. So a funky T wave could be an indicator of some pericardial ischemia or myocardial fluid buildup or edema even. So anyway, keep that in mind as you go. We can also discuss these PQRS and T. So it's the P wave, the QRS complex, and the T wave, atrium depolarizing. In other words, getting told we need you to contract. So bzz, and then contraction. And then ventricles are preparing, they're filling up, and then bzz, we give them a jolt. We need you to contract, and then they contract. And then we have to get everything reset, that repolarization of the ventricles. And then ultimately, what we're going to end up doing is seeing in this area here is where the sodium potassium pumps are kicking in to start to get actual polarization. And then we repeat the cycle. So we can look at on an EKG chart, we can see the P to R interval as well. So we can measure, is this too short from here to here? What's the time or the interval? Generally, and by the way, on an EKG or ECG paper, you're going to see a bunch of squares, and each square represents 0.1 seconds typically. So this P to R interval should be around between 1 and 2 small squares. Okay, and then the QT interval should be less than 4 of these little squares. Okay, so when you're doing EKG readings, you're looking at the squares. We can use on the graph paper, we can look at intervals, we can look at amplitude or height. We can certainly look at the segments in between. If we have remember this, ST segment, the ventricles are ejecting blood and are kind of going back at rest and preparing to ultimately to get more blood from the atria. Okay, so if this ST segment is really short and the T wave is really small, then we may, before we generate another P wave. So sometimes what you'll see is a lack of a T wave and a P wave starting back up. Now, how would we know if we have the lack of a T wave? Well, if I put another QRS wave right here on a normal EKG, there should be a QRS and then a T wave. And then what we'd see is a little P wave and then another QRS. So we should see two little humps with a little bit of a distance between them between contractions. So we should see a QRS and a QRS with a T hump and then a little P hump. If we only see one hump between QRS waves, that we have to determine, or is it the P wave that's missing or the T wave that's missing? If it's the T wave that's missing, and again, T waves generally have a little bit higher amplitude than a P wave. T waves are asymmetrical. P waves also a little bit asymmetrical, but they do have some a little bit more symmetry maybe. So P waves are going to be closer to a QRS wave as well. So when that next QRS wave starts, if we only have one hump and that hump is right before this next QRS, then that's a P wave and we're lacking a T wave. So if we're generating a P wave and a QRS before a T wave is able to show up, that means that the ventricles are unable to relax or be prepared for the optimum amount of blood that they're going to receive after the atria contracts or following a P wave. So these guys eject blood, and then we're not able to get the ions realigned properly before we're already asking for potentially another ventricular contraction. So if this is a P wave and then a QRS wave, the ventricles have contracted. They need a time to relax a little bit and get all of these ions realigned and prepare for the next shipment of blood. So if we jump the gun and give a P wave and a QRS too quickly, then the ventricles aren't going to be, we're going to have a contractility that's going to be down in the dumps. They're not able to relax enough to receive enough blood and then get that optimal contraction and then ejection of blood. So they go through a QRS ejection and then they don't really get to relax again, and they're already getting blood. So they're going to get a short ejection, which means that we're not getting the appropriate amount of oxygen and other nutrients and ions delivered to the body. So anyway, let's see. So showing again outside of the cell, inside of the cell. So we're at rest, we're polarized, all the positives and negatives are aligned. We get an impulse coming in, and you see the positivity inside the cell changes. That's that depolarization that's taking place. Okay. And then as we get all the way across, we're going to start the process of repolarization. So you see we're starting to move negatives back into the cell. Okay. And then we're back to baseline. So again, this is not an EKG necessarily. This is one small portion of what we could possibly see if we isolated just one cardiac cell. This is showing an action potential. Okay. Okay. So again, we're polarized, everything's relaxed. The P wave occurs. So zoom, that means a little bit of electricity has just left that SA node, has traveled over to the left atrium, kind of gone around the right atrium. You can see it traveling a little bit down toward the AV node. Okay, so that's that initial jolt. And then what we get is the contraction of the atria. So the atrial wall is completely depolarized. So we're not going to see any change noted in the EKG reading. We're going to get those atria to contract or eject blood. And then at that same time, as the blood's filling up the ventricles now, and we need to hit the reset button for the atria. So they've just contracted. They now need to relax. So that's where that repolarization is taking place. And then we see the depolarization of these ventricular cells. Uh, and that shows up on the QRS complex. So basically, what we're saying is, hey, as you fill with blood, we're going to get you prepared to eject that blood. And in order to do that, we need a little bit of electricity going through those cardiac muscles. So then QRS wave is concluded. We've given electrical impulses to the muscle. We get a little bit of an flat line here. That's the ventricles contracting and ejecting blood. Again, we're completely depolarized. We're going to see that ejection of blood take place. Nothing's going to show up on the EKG reading at that spot. So again, if we're lacking much of a uh, uh, um, ST interval here, that means these ventricles may not be contracting with very much strength. Okay, and then we need to repolarize everything so the T wave shows up as everything is getting back into alignment. And once we've completely hit repolarization, we can be back to baseline. And we're now back over here to being polarized and awaiting that next electrical impulse. Let's see, that cardiac cycle, systole and diastole. Uh, Again, your PhysioXs go through these, and I explain this in more depth in those videos. So you're going to want to watch those as well. But anyway, the contraction, the systole or the systolic has to do with contraction, and then the relaxation part of it is the diastolic. Okay, so when we look at blood pressure numbers, we see these terms as well: systolic and diastolic, 120 over 80. We also use these in terms of contraction and relaxation of the cardiac muscle. So this from Patton's text shows an EKG and then the associated heart sounds. So this is kind of a cool chart when you break it down. I know some of the I blew it up, so some of the lettering is a little bit smaller, um, but I think, if you have Patton's text, you'll be able to find it. If you hit full screen mode on this slide, it'll blow it up so you can see it a little bit better. But again, we see the heart sounds are the ventricles contracting. So one of the heart sounds, the first heart sound that we see. Yeah. And really what they The heart sounds are the valves. Okay, the lub and dup are the valves. Okay, so we've got the aortic semilunar valves opening up and shutting. Floop, floop. Okay. Let's see, what else was I? Oh, this shows ventricular volume. So again, at the peak of that QRS, okay, we're telling the ventricles to get ready to contract. And notice too, we've stretched this out so we can really see some of these other aspects going on. See that ejection of blood, so ventricular volume goes down. So again, we see. Okay, so the ventricles are filling up, filling up, filling up, filling up, and then we would see the bicuspid and tricuspid valves close. Okay. And then we eject the blood from the heart. And once that volume gets to its peak, we're going to shut the pulmonary and aortic semilunar valves. And we can start filling it back up. So closing of the AV valves, closing of the semilunar valves. So aortic blood flow. So how much blood's in the aorta? Well, as we eject blood from the left ventricle, we should see this go up. And then blood pressure. Yeah. Mitral valve closes. That's what's going on here. Mitral valves closing. Mitral valve opening back up. Aortic valve closing. Okay, so you can see these heart sounds. Mitral valve closing. Aortic valve opening. Okay, so if we're staying on the left side of the heart. Okay, so we've filled up. Okay, filled up the ventricle. Ventricle's closed, or the mitral valve closes. Getting ready to eject that blood. Boop, we have to open the aortic valve. And over here, we close the aortic valve, open up the mitral valve. Okay, so AV valves close, semilunar valves open, semilunar valves close, AV valves open. That's that heart sound that you see there. So this is measuring pressure. We've got aortic blood pressure, left atrial pressure, and left ventricular blood pressure. Okay, so again, as flow and pressure go together, right? So aortic flow, we increase blood flow, we increase pressure in that aorta. Okay. Aortic pressure goes down a little bit. And again, there's that 120. We saw in PhysioX, we saw that we left that at a constant 120. That's that systolic, or the systolic contraction of the heart. Systolic pressure, 120. Okay, notice 80. Zoop, that's the pressure at diastole or diastole, the diastolic or the low number. So between contractions. Okay, and then we get the heart contraction. Vroom, pressure goes up to 120. And then it starts to go back down to 80. We get ventricular contraction, ventricular systole. Okay. The ventricles empty, aorta fills, aortic valve opens, and pressure increases. So anyway, kind of a cool way of putting it all together, basically. Okay, so atrial systole. Remember, systole means a contraction, so the atria contract. So this is the P wave has occurred, and the atria contract. So P wave. P wave would be like just prior to 1. Okay, and then we have isovolumetric contraction. So isovolumetric, so same volume ventricles contract. So this is that QRS area. Okay, so we see the AV valves close, semilunar valves are closed. Okay, so blood, this is that Starling's law at this point too, Frank Starling law, where we're filling and filling and filling and prepping, stretching those sarcomeres, and then boom, we're going to get ejection of the blood. So P wave, atrial systole, QRS wave, isovolumetric contraction, and then ejection. And then we get isovolumetric relaxation. So this is going to be your T wave kicking in as we fill up the atria. And then we're going to get some passive ventricular filling. AV valves open. Okay. P wave kicks in, triggers atrial systole. Okay, so P wave triggers the atrial contraction. Pressure gradient pushes blood out of the atria into those relaxed ventricles. So AV valves are open, semilunar valves closed. Okay, and then the ventricles are relaxed and they're filling with blood from the atria. Okay, and then we're going to get that ventricular systole coinciding with the R wave of the ECG and the appearance of the first heart sound. Okay, so the start of the ventricular systole and the opening of the semilunar valves. Okay, that's that isovolumetric ventricular contraction. Okay, so we're not quite ready to eject it or contract. It's the onset at the beginning. So that's that peak, that R wave. So this is the peak of electricity, peak of impulse. That's going to start the ball rolling for contraction. Okay. And again, we're getting that afterload. Right here, afterload is pushing against. So that's what that isovolumetric, you've got afterload, you've got blood in the aorta that's pushing, causing a pressure. So as we're filling and filling and filling, part of that filling is because there's a pressure. And once we increase this volume enough, stretch it out enough, we can overcome that pressure difference that's keeping that aortic semilunar valve closed. Okay, we overcome that pressure and ejection occurs. Semilunar valves open. Okay. Ventricles, again, that pressure exceeds the pressure for instance, in the aorta or the pulmonary artery. Okay. So increase in ventricular and aortic pressure, aortic blood flow, okay, all this overcoming the pressure causes the blood to be ejected. And then we get a little bit of a reduced ejection after that initial blast. That's going to be that T wave as we're repolarizing and getting everything kind of back into the reset mode. They call that isovolumetric ventricular relaxation. Okay, so that's when diastole or diastole begins for the ventricles, the relaxation phase. So we close these semilunar valves, get the AV valves open a little bit, and get some fill. Start filling the ventricles a little bit. Yeah. Dramatic fall in intraventricular pressure, not enough to open the AV valves, no change in volume. So again, the closing of the AV valves. Okay, so the IVR, isovolumetric ventricular relaxation phase, is between closing of the semilunar valves and the opening of the AV valves. So the AV, it gets kind of confusing. The AV valves are still shut during this. This phase is between closing the SL valves and opening the AV valves. So there's no change in volume. This is, again, that second heart sound. AV valves closing up. Okay, and then that continued relaxation and continued pressure changes as the atria are filling, more pressure is being placed against the AV valves, and at that point we're going to see blood, the valves open. It's like the trap door, the AV valve trap door can't. The pressure building up from the blood entering the atria, it's higher than the pressure in the ventricles. So fluid moves from high pressure to lower pressure. So from you're going to get the trap door, the valves opening. That's going to cause blood to go into the ventricles in a passive manner. And then not all of it, because that's going to trigger then the atria to contract. So again, that systolic sound, the first sound, the contraction of the ventricles and the closing of those AV valves. And then we get that diastolic sound, is the closing of the semilunar valves. Okay. So that's chapter 28. Let's look at 30 for a few minutes here. Hemodynamics. Again, these are the mechanisms that I went through with the PhysioX. So I'm not going to spend a lot of time on this, the rest of this video. A lot of the information is going to be contained in there. So for fear of sounding too repetitive, I'll go through some of the basics here. There are more basics and maybe not so basics in the PhysioX. So hopefully you can blend the two together. And again, always look at the Padlet videos. They're very informative as well. So anyway, hemodynamics. So hemo, of course, we always know has to do with blood, and dynamics, mechanisms of active changing flow. So basically what we're looking at is active and changing blood flow or blood circulation. Okay. So let's see. We can do this a couple different ways, as you'll notice when you do the PhysioX activities. We can increase or decrease the thickness of the blood. We can increase or decrease the radius or diameter of the blood vessel. We can increase or decrease the length of the blood vessel. We can increase heart rate, causing an increase in blood pressure. Okay, so pressure gradients. Okay, P1, P2 is the symbol to represent pressure gradient. So pressure gradient, P1 is high pressure, P2 is low pressure. So 120 over 80, for instance. So PP, the perfusion pressure gradient, is what's needed to maintain blood flow through tissue. So perfusion pressure, how well are we able to get oxygen and carbon dioxide in and out? Okay. So we see the systolic pressure, that higher number, diastolic pressure, that lower number. And again, driving force, we've got 100 millimeters of mercury. So flow rate, we can look at liters per minute. So whenever we look at rate, we're looking at liters per minute. So flow rate of 1 liter per minute. Okay. So flow rate equals the force over the rate. Okay. So those are going to cancel. 100 millimeters of mercury cancels, and 100 millimeters of mercury. So we're left with 1 liter per minute, okay, for flow rate. Okay. So flow rate, force over resistance. I think I may have missaid all of that, but flow rate equals driving force divided by resistance. Okay. In the PhysioX, I go through this in a lot, I guess, more detail, I suppose. So if this is seemingly kind of strange, it should be. So it's okay. You'll get it as we go. So resistance, that's um, how well we're able to move a fluid, for instance. Resistance is dependent on blood pressure. It's dependent on blood thickness or viscosity. It's dependent on the distance of the tube. It's dependent on the radius or the diameter of the tube. So resistance is variable. Okay, so keep that in mind. Resistance is variable. This is not a constant. Blood pressure is something that your body tries to keep constant. Basically, we're dealing with 4 things here. Blood pressure is number 1, and blood pressure is equal to 3 factors multiplied together. Okay, blood pressure or that change in blood pressure is equal to stroke volume, heart rate, and resistance. So when we want to maintain blood pressure, we have to maintain those other 3. Okay, resistance, stroke volume, and heart rate. Okay, stroke volume generally is kept in a small range, just like blood pressure. Okay, stroke volume and blood pressure are generally kept constant as much as possible. So anyway, I'll get into that in more detail a little bit in this video, but already in the PhysioX Activity 5 videos. So anyway, notice blood pressure. Again, we studied it at the aorta and the larger arteries. That's where we see that 120/80. As we get further and further away from the left ventricle. Okay, so the left ventricle ejecting blood into the aorta is creating the greatest amount of pressure. As we get further and further away, we see pressure decrease all the way to the point that we get back to the heart. So remember, from the left side of the heart back to the right side of the heart is just one continuous group of of tubes. It's one long tube with a bunch of different little side roads or side tunnels that still ultimately all reconnect back to the inferior and superior vena cava. So the blood pressure back at the right atrium is going to be very, very low. That's why we don't measure blood pressure at that area. We don't do venous blood pressure at the vena cava. Notice this is all veins. So blood pressure in veins is going to be very low. Blood pressure in arteries is what we're measuring when we measure blood pressure. Because again, heart contracts, ejects blood into these arteries. Okay, so cardiac output is also known as blood flow. So that is key to remember. Blood flow and cardiac output are the same thing. Cardiac output is determined by multiplying heart rate. So how many times is your heart beat per minute And then how much blood is ejected per beat. They call that stroke volume. So stroke volume, again, is simply how much blood is ejected each time the ventricle contracts. Okay. It's a range to around 70 milliliters. Okay. So cardiac output, how much blood gets pumped out in 1 minute? Okay. And that can be determined simply by multiplying heart rate times stroke volume. Heart rate generally is around 70 beats per minute. Stroke volume is around 70 milliliters. So normal cardiac output is around 70 times 70, which is around 5,000. It's 4,900, but 5,000 is kind of the baseline number for cardiac output. 5 liters per minute, or 5,000 milliliters per minute. Okay. Pressure, volume, and pressure are related to one another. Okay. They're directly proportional. They're not inversely. As volume goes up, pressure goes up. Okay. So if I eject a greater volume of blood, I'm going to see a greater amount of pressure. That's all that's trying to say. Okay, so if I increase arterial blood pressure, I'm going to see an increase in arterial blood volume. Okay, well, let's work it back up to the top and come back down to an increase in blood pressure. Most of what we see in the clinic is we see a lot of high blood pressure. We see a lot of chronic hypertension. So here are the factors that can determine an increase in blood pressure. And this is normal, right? Blood pressure goes up when we wake up in the morning and get out of bed. Okay. When you sleep, blood pressure is lower. When you wake up and get your day going, blood pressure goes up. So it's okay to see fluctuations in blood pressure. We just don't want to see dramatic fluctuations, or we don't want to see chronically high blood pressure. And here's what's going on and what maybe caused it. Stroke volume. If I increase, so any one of these, remember, blood pressure is stroke volume times heart rate times resistance. So if any one of these goes up, then one of them has to go down in order to keep this balanced. All right, so let's stick on this side. Stroke volume and heart rate. Again, that should ring a bell. That's cardiac output. Okay, so if stroke volume goes up and we leave heart rate alone, cardiac output's still going to go up. If stroke volume is maintained as a constant, but heart rate goes up, cardiac output would go up. Okay, does that make sense? If this is 3 and this is 3, this is 9. 3 times 3 is 9. If I have 3 milliliters of blood and I pump that blood 3 times in 1 minute, I'm going to get 9 milliliters pumped out in 1 minute. If I increase either one of these, so this stays 3 and this goes to 5. So every time I beat the heart, I get 3 milliliters of blood, but now I'm going to beat it 5 times. That means cardiac output is now 3 times 5, or 15 milliliters per minute. Again, those are hypothetical numbers. Those are not the real numbers. Those are just bringing it down to tiny math. Certainly, if either one of them, if they both go up, if this goes to 5 and this goes to 10, then this is going to go to 50. So of course, we're going to see this go up if both of them do. Both of them don't have to go up, though. Again, this could stay at 70 milliliters. This could be at 70. That gives us 4,900, or 4.9 liters per minute. If this goes up to 100, this stays at 70. This goes up to 100 beats per minute. Now my cardiac output is 7,000 or 7 liters of blood pumped per minute. And remember, increase in volume means an increase in pressure. Oh, pardon me. Yeah, tickle. Okay. So increase in volume, stroke volume, increase in heart rate leads to an increase in cardiac output. That means we've increased the volume of blood that's entering into the body's systemic circuit. Volume, okay, arterial blood volume is increased. That means we're going to get an increase in blood pressure. Okay, so any one of these two, either one of these two goes up, this is going to go up. The other thing we look at is peripheral resistance. Resistance, generally we see two factors relating to resistance. And again, the PhysioX, you'll actually alter these two. We do radius in PhysioX. The diameter, radius, doesn't matter. We're talking about the size of the hole, or of the lumen, size of the tube. Okay. Increase in blood viscosity. So viscosity deals with thickness. Increase thickness, increase resistance. Thicker blood creates more resistance. Difficult to move as well. Okay. Increase in blood volume. Diameter of arterioles. If I decrease the diameter or decrease the radius of a blood vessel, it increases resistance. That's just saying a smaller tube has more pressure, has more resistance. Therefore, there's more pressure. Okay, so it's the difference between trying to blow water through a juice box straw versus blowing water through a regular straw versus blowing water through a garden hose versus a fire hose, and so on. The bigger the tube, the bigger the diameter, the less resistance. Okay, so decrease in diameter, increase in resistance. We talk about volume of blood that leaves the arteries per minute, arterial runoff. This is the amount of blood that's going to the capillaries. So, so how do I get blood volume to stay normal? Well, I have to get it ultimately to the capillary networks throughout the body. So if the blood's thicker, the diameter of these arterioles as they're dumping into capillary beds has decreased. So we see vasoconstriction of arterioles. That increases peripheral resistance. That's going to decrease the amount of blood that's able to run off into the capillary beds. That leads to more blood volume. Again, more blood, higher blood pressure. Okay, so excess resistance, heart rate, stroke volume. If any of these three go up, okay, so let's leave this as, we'll just use it like a scale of 1 to 5. Okay, if we keep 5 being really thick blood and really small arteries, so trying basically to drink or blow a Dairy Queen Blizzard through a juice box straw, super thick material going through a super small straw. Okay, that's a lot of resistance. Okay, that'd be a 5. Okay, so we're going to leave it at a 1. And we're going to leave stroke volume at 70. Okay, and heart rate normally at a 70. So if we'll say 4,900 for what we're, when we multiply these. Now, if I increase heart rate to 100, now I remember at 70 times 100, that's 7,000 now. Okay. Resistance didn't change at all, but blood pressure went up. Okay? So my point is, I only have to change one of these. So what your body will do to compensate for one of these being off is it will potentially try to decrease one of the other ones. So if heart rate goes up, but I need blood pressure to stay constant, then I either can decrease stroke volume or decrease peripheral resistance. Okay. If heart rate goes up, but I want to keep blood pressure constant, one of these has to go down. So if our normal is 5,000, okay, our normal number, we'll say, is 5,000. Okay. If heart rate goes up to 100, and this stays at 70, now this is 7,000. Well, what if I decrease this number? I need this to stay at 5,000. I could decrease this to 50. So stroke volume is 50, heart rate is 100. Now we're at 5,000. Do you see? I can increase. If one increases, the other can decrease. And sometimes that happens naturally, right? If your heart rate increases and during exercise, you're unable to fill the ventricle between beats with the normal at rest amount of blood. So heart rate goes up, stroke volume goes down. Usually that is enough to compensate this. But another thing I could do by resisting peripheral resistance is, so how do I reduce peripheral resistance? Vasodilation and thinning out the blood, or a decrease in blood viscosity. Okay. So this is why if you have high blood pressure, you get put on blood thinners oftentimes. Okay. So we can clinically alter one of these items. Okay. Put you on a statin or a anti-cholesterol drug. Okay. So anyhow, this chart is probably the bread and butter, really, of the basics of understanding hemodynamics. So I'm not going to spend too much more time. This video is about over. This graphic gives you some ideas of where all this blood's going. So when we send, we're getting, again, that cardiac output of about 5 liters per minute, or 5,000 milliliters per minute. Hey, where does it get distributed? Well, again, we're at 120 millimeters of mercury. As we get further and further from the heart, we're at 104 millimeters of mercury. And then we're going to see, again, that blood pressure continue to go down, right? As we get further and further and further away. Again, smaller diameters. Okay. 700 of the 5,000, 700's going to the brain, 225,000, and so on. So it's kind of cool. You can see where all the blood is traveling to. And again, notice blood amount in should equal blood amount out. Okay, so cardiac output is maintained at about 5 liters per minute. Again, exercise, it's going to go up potentially. Okay. But the idea, really, like I say, is if heart rate goes up, we're going to see a decrease in stroke volume. So we may maintain this. If we have clogging, though, in arterioles, or we have diameter issues, we have issues with producing the right, your body produces blood thinners. Your body produces anti-inflammatories. Your body is able to produce the proper hormones and neurotransmitters that alter diameter or radius of arteria that cause vasoconstriction, vasodilation. Hey, so if we're lacking some of those hormones or some of those neurotransmitters or some of the enzymes that enable these to be balanced, that can alter this. Maybe the person's perfectly healthy over here, but they still have high blood pressure. So we need to look at what is maybe causing all of this peripheral resistance. Is it something physical? Is it something chemical? Is it both? Is it lack of something, excess of something else? So anyway, here's a bunch of goodies for you. Another way, cardiac output. If we could also look at stroke volume around 83, and heart rate around 60. Again, this could be 70 and 70. So either way, we're trying to maintain at 5,000 milliliters per minute. And again, what affects stroke volume? That's that Frank Starling mechanism. Simply, it's the rubber band theory. The more volume causes the more stretch of the sarcomeres, which then, when they're released, they create a stronger force of contraction and therefore an increased volume. So the longer or more stretched the fibers are, the stronger the contraction. And the amount of blood at the end of diastole determines the amount of stretch, or what we call preload. So preload is that amount of stretch that's placed as the ventricles have filled up. We call that diastole, or the diastolic aspect. And then once we, so again, the amount of load determines the amount of stretch, which then determines the amount of force of contraction. So the myocardium contracts with enough strength to match its load with each stroke. So again, stretch it out, build up a lot of potential energy there, and then as it triggers or responds or contracts, we called this the length tension relationship, by the way, when we looked at skeletal muscles. The same principle. Length tension. The longer it is, the more tension there is, and the more force of contraction that we're going to have. So again, what affects stroke volume? Okay, what affects how much blood is ejected per beat? Certainly chemical factors, epinephrine and norepinephrine, stress, exercise, these things, emotional stress, physical stress, these all will increase strength of contraction and thus increase stroke volume. So we can also look at what's called the ejection fraction. That's how much of the stroke volume and the ratio of stroke volume to end diastolic volume. So what this means is, okay, end diastolic volume has to do with how much blood is available to eject. Stroke volume is how much blood was actually ejected. So we could call that end systolic volume. Okay, so end diastolic volume is how much blood is ready to be ejected. So if we say there's 120 milliliters of blood in the ventricle after it's filled to maximum capacity, 120 we'll say, and then the ventricles contract and the stroke volume is 70, then we're left with an end systolic volume of 50. So we can look at end systolic volume is end diastolic volume minus stroke volume. And then we can get a percentage of that. And in essence, I've got 120 milliliters of blood and I only ejected 70 milliliters. So I have 50 left over. So 50 out of a possible 120 is left over. Or we can look at it as the ejection fraction is stroke volume of 70, and I started with 120. So anyway, 70 divided by 120 times 100. So is around 55%. So 60 over 120 is 50%. So again, how much blood is ejected is a stroke volume. How much blood is available to be ejected is what we call the end diastolic volume. So you basically have three steps. So end diastolic volume is how much blood is in the ventricle. Stroke volume is how much blood it was able to eject. End systolic, that's, remember, ejection or contraction is systole. So then end systolic volume is how much is left over. I started with 120, end diastolic volume. I ejected 70, that's stroke volume. I have 50 left over, that's end systolic volume. So we can take that 50 away and we can look at ejection fraction. Simply, it's a fraction. I know algebra, percentages, ratios. Don't worry, it's very straightforward. I've got 120 to get rid of, and I only got rid of 70. So what percentage did I get rid of? I got rid of 70 out of 120. 70 out of 120. Simply divide 70 divided by 120, multiply that by 100, that gives you your percentage. So baroreceptors, I mentioned those pressure receptors. These are those afferent or sensory pathways. We have them in the carotid arteries too. So these are sending signals primarily to that cardiac control center in the brainstem, to the cardiorhythmicity. We've got the pneumo centers for breathing. There's a lot of activity up here in the brainstem that's going to be receiving that information. Oh, let's see. We looked at this again. Resistance, it has to do with viscosity and diameter or radius of the arterioles. Vasodilation, less resistance. Vasoconstriction, more resistance. Okay. Arterial blood pressure varies directly with peripheral resistance. Again, more resistance, more volume, more pressure. Okay, so the other one we looked at in PhysioX too was length of the arterial or of the vessel. If I increase the length, that can alter flow, that can cause resistance issues. By taking a tube that's normally this long and stretching that tube out, kind of like a balloon. Take a tube balloon and you stretch it way out, the diameter of the balloon decreases. So again, that causes more resistance. We see that with obesity, where the capillaries of the adipocytes or the adipose cells, as the adipose cell increases in diameter and size or circumference, we see the capillaries that are wrapped around that adipocyte, as it gets bigger, these stretch out. The little tubes or capillaries around that adipocyte, as it gets bigger, they get more stretched out. And as they get stretched out, the diameter, they go from larger diameter to smaller diameter. They vasoconstrict, in essence, just by being stretched out. That causes an increase in blood pressure. So we relate obesity with higher blood pressure as well. This is one of the reasons why. So anyhow, vasomotor, again, pressor reflexes. We've got the aortic and carotid baroreceptors that are sending signals to that cardiac control center in the medulla. And then depending on what type of pressures are triggering, we may have to get we may get a sympathetic response. We may get some vasodilation in some areas, vasoconstriction in others, increase in pressure in some areas, decrease in pressure in others, an increase in heart rate. We see that vagus nerve also involved. So maybe the perception is everything is fine. So we're going to just perpetuate that parasympathetic response. Yeah, we also have chemo reflexes too. So if there's a pH problem in the blood, a decrease in pH means an increase in hydrogen ion concentration, an increase in carbon dioxide. So we can also measure some of the chemical aspects that are, and those can get delivered to the chemoreceptors in the medulla. Venous pumps. Oh, this is where it ends. This is how do we get blood back to the heart? We know how easy it is to get blood to the heart or get oxygenated blood. How do we get venous blood back to the heart? Inhalations and exhalations are one of the primary methods we see. Okay. The diaphragm works in essence like a pump to squeeze blood up. We also see veins being embedded and in between muscles. So contracting muscles act as pumps as well. So again, this is why sedentary lifestyle is not a good idea because working your respiratory system, working your skeletal muscles does enable better venous flow to optimizes venous flow back to the heart. So, hey, let's see, blood volume, hydrostatic pressure. Oh, blood volume can be altered a little bit with usually blood volume and viscosity kind of go hand in hand, because if we want to increase blood volume, oftentimes it has to do with moving ions into or out of the bloodstream. And ADH or antidiuretic hormone has to do with triggering more reabsorption of sodium in the kidneys, thus leading to more reabsorption of water in the kidneys. And um, so that can cause an increase in blood volume. So I'm not going to be urinating as frequently if I'm dehydrated. So antidiuretic hormone will keep blood volume higher or at a level it needs to be. So plasma volume, again, regulated by this RAAS, renin, aldosterone, angiotensin system. Again, if we need to retain fluid, we're going to get antidiuretic hormone from the pituitary release. That's going to go to the kidneys and trigger a series of chemical reaction. One has to do with decreasing fluid and sodium loss in the urine. So that's one of the main keys we need to do is retain sodium, thus retaining fluid. One of that RAS system, it's triggered by a hormone called renin and aldosterone. And aldosterone is going to trigger potassium balance as well. And then, potassium, sodium retention. And so aldosterone triggers sodium retention. ADH triggers fluid to follow that pathway. Basically, ADH is kind of like the precursor to the renin and aldosterone. Aldosterone getting triggered by antidiuretic hormone causes sodium to be retained. We've looked at this before. I don't know why I'm going back through this, but as a reminder, ADH and aldosterone cause you to retain water. Okay, and that would increase blood volume. So angiotensin, angiotensinogen, renin or renin causes angiotensinogen to be produced. That causes angiotensin 1, ACE, and angiotensin 2. Angiotensin 1 may triggers vasoconstriction. One triggers vasodilation. So one switch turns on, the other one is a switch that turns things off. We're going to look a little bit more at this next chapter. Competency 8, we go through the urinary system. Competency 9, we go through perfusion. So I just want to introduce you. Well, I've already kind of introduced you to it with the immune system, but here it is again. Renin released when blood pressure is low. So if blood pressure in the kidneys is low, that triggers aldosterone secretion, which triggers sodium retention, which triggers water retention. So if the blood pressure in the kidneys is low, it could mean that the body perceives you as being dehydrated. So angiotensin 2 will cause some vasoconstriction, which complements volume increasing effects. So again, we want to increase volume, vasoconstriction in certain areas. Again, triggered during stress is going to cause an increase in overall blood flow. ANH is the shutoff mechanism. Atrial natriuretic hormone increases sodium loss. So then water chases sodium. So that's going to be sodium loss. Okay. So arterial blood pressure, again, we looked at systolic and diastolic. Pulse pressure is the difference between the two. And oftentimes that's the number that we're maybe a little bit more interested in. Sometimes is making sure that number is around 40 millimeters of mercury. We're getting 120 over 80. Okay, so systolic is the pressure that's exerted on the inside of an artery wall after the ventricles have contracted. Diastolic is the force of the blood pushing against the artery walls during isovolumetric ventricular contraction, or basically saying when the ventricles are filling with blood. Okay, so when the ventricles are filling with blood, they're relaxed, we're in between contractions. That's the diastolic pressure. Okay, so systolic, boom, we get a contraction of the ventricle, we increase pressure, and then we're relaxed, ventricles are filling, and then boom, we get another pressure. So that 80 is the amount of pressure in the arteries between contractions. 120 is the amount of pressure in the artery after a contraction. This chart is we could do a whole semester, maybe a whole 50-minute video just on this particular chart. But take a look at that. It's a nice review chart. It goes through a lot of what we talk about in this, what we've talked about in this particular video, but also things we've talked about in other videos. It has some teasers for what we're going to talk about in some upcoming videos. So anyhow, this is a tremendously on the surface complicated looking chart, but I think if you really take it step by step and break it down, you really start to see some of the puzzle pieces come together of what we've done the first 6+ weeks of this semester. So anyhow, this chart is awesome. Take a look at it. I think I'm about done here. Different pulse points. Okay. Radial pulse, brachial pulse, axillary pulse, femoral, popliteal pulse. Okay, so those are just the different pulse points. Again, that's every time we can measure heart rate by checking pulse points. So heart rate, stroke volume equal cardiac output. So what is and blood pressure? So what you measure in the clinic is blood pressure. You can measure pulse rate or heart rate as well. You could potentially measure some of the viscosity of blood by doing blood draws, but we could determine. We could potentially determine cardiac output based on blood pressure, stroke volume, or heart rate. Because stroke volume is more difficult to measure, I suppose, without having the numbers. It's kind of like the X factor, but you can solve for X when you know blood pressure, when you know heart rate. So anyway, hope you enjoyed this video. Stay tuned for more. If you have questions, certainly email me and let me know, and I'll get back to you as soon as I can.